co-sponsored by the Preventive Medicine Residency Program. I am Isaac Armistead, the lead preventive medicine resident. Our speakers today are Dr. Rachel Herlihy, the Communicable Disease Branch Chief and State Epidemiologist at the Colorado Department of Public Health and Environment, and Kirk Bol, Manager of the Vital Statistics at the Colorado Department of Public Health and Environment as well. Their talk will be on the Colorado state of the state from a public health epidemiology perspective. Today's seminar is being recorded and we will have time for questions at the end of the talk. You are invited to place your questions in the chat. With that, I will turn it over to our speakers.
Great, thank you so much, Isaac. And thank you all for the opportunity to be here today. I'm honored to be here on behalf of CDPHE to provide you with an update on the state of public health in Colorado. But in a break from our traditional state of the state presentation, where we usually talk about the breadth of public health work in Colorado, today we're actually going to focus primarily just in on COVID. And I'm sure that comes as no surprise because it's 2020 and COVID has really defined our lives. So public health is in the spotlight. I no longer need to define epidemiologists when I meet new people. Though I should say I'm actually probably also not meeting very many new people these days. So there's that. But I did recently give a presentation to a couple of 7th grade classes. And they were studying viruses and bacteria. And as I was interacting with them and asking them questions, I asked them to define epidemiology. And they didn't miss a beat. And that's really cool that public health is so in the spotlight, epidemiology is so in the spotlight that people really understand the work that we're doing right now and are valuing the work that we're doing. I'm certain that COVID will define my career and probably many of yours. My husband actually calls this my really morbid Super Bowl. But from my state epi bubble, it sometimes seems easy to forget that it's really not just me and my team who are consumed by COVID right now, but it's really all of public health and really even all of society that is impacted by this virus right now. And so it really feels right to give COVID even more time in the spotlight today during this State of the State presentation. So specifically, I'm going to talk about the direct impacts of the SARS-CoV-2 virus in Colorado and the epidemic here, and talk about where we might be headed in the next couple of weeks. Kirk Bol, then, who directs our state's Vital Statistics program, will provide you with an overview of some really interesting work that we're doing right now to try and understand how COVID has indirectly impacted the public's health in Colorado. It's been a pretty overwhelming 8 months that has put incredible strain on our public health system. In those first few months of our response, it really has seemed like there's never enough time and never enough people. And some days it really still feels like that, but we are starting to find our stride and we have built an incredible team. So this shows you before and after org charts for our communicable disease branch, where our communicable disease epidemiologists work. This, of course, does not include our state lab or our emergency preparedness program, where there's also been a ton of growth. But you can see that we have quadrupled in size. It's actually nearly impossible, even when it's printed, to read this org chart on the right side now. So our staff has grown from about 50 to now more than 200. And again, that's not the breadth of our COVID work. This is really just the communicable disease epidemiology work that's happening at the state health department. So also not accounting for the incredible growth and the incredible amount of work that is happening at our local public health agencies as well. But also key to our success has really been multiple partnerships with the Colorado School of Public Health. And I don't want to have this presentation conclude without acknowledging the incredible work that the School of Public Health has contributed to the state's response to COVID-19. So that's an ongoing partnership with a modeling team, which actually includes representatives from multiple academic institutions across the state. A close collaborative relationship with the preventive medicine residency program. We've had multiple residents that have rotated, and now actually some of them become employees of CDPHE. and our large group of case investigators and contact tracers and students that are working on our emerging infections program to really do a lion's share of the case investigation and contact tracing work that's happening in the state. So incredibly grateful to all of these individuals and to the school for an incredible partnership and the way that you have supported the state in providing resources to us to really expand the work that we are doing. So I'd like to now turn to the data. So this first slide shows you cumulative COVID-19 cases in the US by state. And so what stands out here is that Colorado is among the states that has had an overall lower incidence of COVID-19 in comparison. We've certainly heard recent stories about large epidemics that have occurred in some of our Western state neighbors. We all, of course, know the experience of New York early on in the epidemic here in the US. And we've been fortunate here in Colorado that up until this point, at least, we've had actually relatively low case counts compared to some of our neighboring states. And here's the data when you look at it longitudinally. So you can see the case burden with a 7-day rolling average number of new cases per 100,000 for the US overall and then Colorado. So you can see obviously we had a significant increase in cases with this spring wave of illness. But since that time, we've really been able to maintain much lower overall rates of disease than we've seen in much of the country. And this, I think, is a success for Colorado, that we've continued to have lower rates of disease in the last couple of months, since putting our strong team together and using data for decision making and policy making here in the state. So this is a figure that shows you where Colorado stands for our 7-day incidence compared to other states in the country. And once again, you can see that we're doing quite well. Our 7-day incidence is low compared to many other states in the country. And so we're certainly feeling proud of our response at this point. Similarly, this map shows you the number of consecutive days of the downward trajectory in case reports from states across the country. Again, Colorado is in a pretty good place here in comparison to other states with where we are as far as the number of days we've been in a downward trajectory. Similarly, this figure shows you number of new deaths that have occurred in the last 2 weeks across states in the US. And again, you can see that Colorado has been in a good position in comparison to some of our neighboring states. But I think the story looks a little bit differently when you zoom out and you sort of look at Colorado's experience and the US experience compared to the rest of the globe, especially if you focus in on what has happened in the last 2 weeks. So what I've done here is taken a map from the European CDC, and I obviously included this little probably oversized rectangle for Colorado here, but just to show you sort of where we are compared to the rest of the US on average, and then where we compare to the rest of the globe right now. And I think we all know that compared to the rest of the globe, that the US has struggled, and we have had higher burdens of disease than many other developed countries around the globe. And I think this really points out where we are really falling behind many countries in Asia, certainly Australia, New Zealand, and many countries in Europe as well. And so while our position here in Colorado looks more favorable, I think, than the overall rates we've seen in the US, we are still, I think, falling short of where many developed countries are at this point. And so I want to move now to talk a little bit about where we might be headed in the next couple of weeks, and also talk a little bit about how we are using data for decision making, how we're using data to really drive some of our policy decisions in the state. So you'll see here that I have circled the week of July 5th, and I want to come back to this in just a little bit. But while we're on this figure, I want to point out this rapid acceleration we saw in cases the week of July 5th. So this really started, we think, at the beginning of the 4th of July holiday weekend, and really carried on for a couple of weeks, where we saw this rapid acceleration in the number of cases in the state. And we were responsive in identifying that rapid acceleration and making some policy changes that I think successfully led to a decrease in the amount of transmission occurring here in the state. Unfortunately, where we've been for the last couple of weeks is a bit of a plateau. So you can see that in late July and early August, we were really seeing this pretty rapid decline in the number of cases occurring in the state. But it's really been over the last 4 weeks or so that we've entered into this plateau phase. And I think we're starting to see some early signs once again that we could be entering a growth phase in the state. And so I want to talk a little bit more about that later in the presentation. But remember, I want to focus back on this rapid acceleration we saw in July, and then we'll talk more about this plateau we're experiencing and what it might mean for the next couple of weeks to come. So if you look at that plateau, when you dig a little bit deeper into the data, we notice some age-specific trends. And so what I'm pointing out to you here is this age-specific figure that shows you in this 10 to 19-year-old age group, we have seen a pretty significant increase in the overall rate of disease. And this was actually a little surprising to us when we saw this last week, because earlier on in the summer, we saw this rapid increase in 20 to 29-year-olds. And thinking in general about where we were expecting disease trends to be increasing in the state right now, we expected that we were going to once again be seeing an increase in this 20 to 29-year-old population. So it confused us a little bit to see this increase in 10 to 19-year-olds. Was it potentially due to transmission occurring in school-age children, or was it something else? And so we dug into the age-specific data a little bit deeper. And what we found was really interesting. So it turns out that that age-specific increase that we were seeing in that 10 to 19-year-old population was really 18 to 19-year-olds. So those very younger college students were really driving the increase in that age group. If you look specifically at the 10 to 17-year-olds that were as part of that age group, there was really very little difference in transmission occurring among those school-age children. So really what we're seeing just in the last week is this rapid increase in disease transmission among 18 to 19-year-olds, so college freshmen and sophomores, and also a similar increase in all college-age students, but primarily we're seeing the greatest increase in those younger college students. And similarly, I think another sort of factor when you look just at case-specific data, where the data is not truly what it appears to be necessarily, is the fact that we know that there is substantial underreporting of cases occurring in the state. And that has improved over time, but I think it's important to put in perspective how much disease transmission is occurring now compared to what we saw in the spring. And that's not immediately apparent when you look at our case count data. And so what this figure shows you is this solid line shows you the number of cases that have been reported to public health. So this is what's actually reported to public health. The dotted line here shows you the estimated number of cases we believe to have occurred in the state. And this is work that is being done by the School of Public Health's modeling team that really extrapolates from the number of hospitalizations occurring, the number of cases we believe have occurred over time. And so even when you look at these two different epi curves, and I can show you back this figure here, you look at these two different curves, they look fairly similar in size. But when you look at the reality of what's been happening, the second wave of illness we experienced was probably much smaller than that first wave of illness. And the difference really is the amount of testing that's been occurring in the state. So this figure shows you the amount of testing that's been occurring on a daily basis across the state. The green color represents testing that's being done at commercial laboratories, and the tan color represents testing that's being done at the state public health lab. So what you can see here is a dramatic increase in the overall amount of testing that's happening. And then corresponding with that is a dramatic decrease in the overall percent positivity. And so we track percent positivity as for really two reasons. It helps us really interpret case level data when the amount of testing is changing over time. So we can really best understand if the burden of disease that we're seeing is potentially due to changes in testing volume. It also is another way for us to really try and understand whether or not we have an adequate amount of testing occurring in the state. One of the goals that has been set out by the World Health Organization is that locations should have no greater than 5% positivity to assure that adequate surveillance testing is being performed. And so what you can see in this figure is that we've been hovering right around this 3% mark of percent positivity for the last few weeks in the state. And so we're in a much better place with the amount of testing that we have available in the state, and we believe that sufficient testing is occurring right now for us to have a good sense of where disease transmission is occurring and how much disease transmission is occurring in the state. So this figure shows you our overall percent positivity trend, and this is similar to the case figure that I showed you, where the blue lines here represent weeks where we see a week-over-week decrease in the number of cases occurring, and the bars that are in red show you the weeks where we're seeing a week-over-week increase in the number of cases occurring. And so what you can see, once again, is that for the last 4 weeks or so, we've been in this plateau phase where we've really been in a place where the numbers are sort of up and down a little bit. We think that there's some instability here. We know that it's really difficult when there continues to be a highly susceptible population to really maintain an equilibrium in the number of cases that are occurring. And so we anticipate that, you know, potentially over the next couple of weeks, we could see an increase in the number of cases that are occurring, or ideally we would love to see a decrease in the number of cases occurring, but staying in this plateau phase for an extended period of time, given what we know about infectious disease dynamics and the highly susceptible population that remains, seems to be unlikely. So I want to talk a little bit about hospital admissions data. And so this is a similar figure that shows you week over week whether or not we've seen an increase or a decrease in the number of hospitalizations that are occurring in the state. And so what you can see here is that, once again, as I showed you with the case data, around the week of July 5th, we saw a rapid increase in the number of new hospital admissions occurring in the state. And once again, you can see when we look at hospitalization data, we've seen this relative plateau for the last couple of weeks in the state, where we've seen really flat levels of new admissions occurring in Colorado hospitals. And so the reason I wanted to talk a little bit more about hospitalization data is that this hospitalization data is the data that we are using together with the School of Public Health modeling team to try and do some forecasting and make some projections around potential disease transmission in the state. We're also using this data to really try and understand what potential impacts different control strategies might have. So if we implement a particular disease control strategy, what sort of change in the level of disease transmission might we expect to be? And so this comes back to flattening the curve. So if you look at this red curve here as, you know, being the situation we're trying to avoid, where we see a dramatic increase in the amount of disease transmission occurring, and this blue curve being more of a manageable sort of level of disease transmission, this is really what we're trying to achieve. So we're monitoring disease transmission in the state with the goal of trying to stay below some sort of a threshold. And the threshold that we're using right now to define much of our policy decision-making is the number of ICU beds that are available. So we know that our healthcare system, particularly our intensive care services in the state, are really what are potentially a limiting resource in the amount of healthcare that we can provide to the most sick individuals in the state. And so what we're doing is monitoring the data closely. When we see concerning trends, concerning acceleration in the amount of cases, percent positivity, or hospitalizations that are occurring in the state, that's really when we start turning to some of the policy levers that we have available to us to try and bend the curve and suppress transmission of disease back down to a more manageable level of disease. And so some of the things that we've used since the beginning of the pandemic include things like a stay-at-home order, obviously, early on. We've implemented school closures, bar, restaurant, and other business closures, limiting indoor capacity, canceling mass gatherings, mask order across the state, and then, of course, public education campaigns as well, so that individuals know potential risk in their community and know actions that they can take to potentially protect themselves from disease transmission, all while at the same time building healthcare capacity in the state. And so going back to those figures that I showed you, where we saw this rapid acceleration around the week of July 5th, that is exactly what we did together with the governor's office. We evaluated the data. We saw this concerning level of increased transmission in the state, and we used the data for decision making. And so what came out of that around that time was the mask order that the governor implemented, and also the earlier last call in the state. So no alcohol sales after 10 p.m., which has been shifted back now to 11 p.m., were some of the policy recommendations that came out of that time. And specifically the alcohol last call order, one of the goals behind that was to specifically address those age groups where we were seeing the highest levels of disease transmission. I mentioned earlier that it was that time in July that we were really seeing the highest rates of disease transmission occurring among that 20 to 29-year-old population. And so we were looking for potential interventions that would specifically address disease transmission in that population in particular. And so what these two different figures show you are different fits of the model. So this is the modeling work, again, that the school public health modeling team is doing. And what you can see here with these colorful lines is different fits of the model to observed hospitalization data. So each of these vertical bars corresponds to observed number of hospitalizations that have occurred in the state. And so each of these colorful lines represents different levels of social distancing or different levels of the effective reproductive number, or that R value that we talk about. And so this work that we were doing back in July corresponds to that rapid increase we were observing in hospitalizations, and work we were doing with the modeling team to try and figure out what transmission in the state could potentially look like if we continued to see the low levels of social distancing and the high effective reproductive number that we were observing at the state. In the state. So the red line that you see here corresponds to the level of social distancing that we were seeing really during the stay-at-home period of time and early and safer at home period of time. So moving on into the early part of the summer. As we started some reopening in the state, we transitioned to more of this turquoise line. The model fit here in this early period of time was this turquoise line, which is an effective reproductive number of just above 1 and a level of social distancing of about 65%. What happened in early July with a fit of the model is we observed this rapid increase in the number of hospitalizations occurring in the state, and a potential rapid increase over time if we did not course correct and increase the level of social distancing or effectively decrease that reproductive number in the state. And so again, this is some of the data that led to that decision making. So using modeling to try and anticipate what disease transmission would look like, and using modeling data to help us drive decision making in the state with data. So again, this is the model fit back in July when we were seeing that rapid acceleration. The figure on the right here shows you the model fit much more recently. And so you can see we were in a good place. If you look at the model fit the last 2 weeks of August, a relatively good fit where we were, good place where we were seeing a continued decline in the number of hospitalizations. Unfortunately, in the last week or so, we have started to see more of this clear plateau and a potential slight increase in trends in the state. And so we're now at a place where we believe the effective reproductive number is once again above 1, and our level of social distancing is probably drifting below the level we want to see it. So I want to talk a little bit about the effective reproductive number and how we use this. So this effective reproductive number, or this R value, really corresponds to, on average, how many individuals go on to be infected by a single case of an infectious disease. And so early on in Colorado, we observed this effective reproductive number to be in the range of 2, 3. We were able to suppress disease transmission by increasing social distancing in the state, and saw, in effect, that effective reproductive number decrease to less than 1, which is ideally where we want it to be, because when one Coloradan is infecting less than one Coloradan, that's really where we can see the epidemic in the state shrink. We saw that increase for a period of time in July, but since late July, we had been in a relatively good place with this reproductive number below 1 for several weeks. Unfortunately, with the most recent fit of the model, it does look like the effective reproductive number now is potentially above 1 once again. We're paying close attention to the data. We do appear to be really in more of a plateau, not rapid acceleration of the data of the cases at this point, but again, watching that trend very carefully and really trying to understand where we might go in the next couple of weeks. So some potential possible impacts to social distancing in the near future, and potential impacts to that effective reproductive number and the level of overall disease transmission occurring in the state. include things like school reopenings, colleges and universities reopening. So given the timing of when those reopenings occurred, it was really starting at the very end of August that we believed we could start seeing some potential impact. So it could be that that's really much of what we're observing right now with this flattening trend, this plateau or potential slight increase we're seeing in the last couple of weeks. And similarly, as I mentioned around the 4th of July holiday, we did see a burst of disease transmission in the state that we believe corresponded to this burst of decreased social distancing around the holiday weekend. So we're certainly concerned that we might see that again following the Labor Day holiday weekend. And we expect to start seeing that potential impact any day now. Also moving into the fall, longer term, potential impacts to the healthcare system in particular are the influenza season. And we're certainly hearing good news from the Southern Hemisphere that influenza transmission in the Southern Hemisphere has been minimal, but I think it's still too soon to know what level of impact influenza might have in the US and Colorado and what that impact might be on our healthcare system in general. And so, of course, it's important more now than ever to ensure that Coloradans are receiving their influenza vaccine. And so I want to talk about the next couple of weeks and what they might look like. And once again, this is work that comes from the School of Public Health's modeling group. And what you can see here is potential levels of disease transmission, specifically as they correlate to what our ICU bed demand might be in the state. And so the current level of social distancing is shown here in the light blue, really overlapping very much with this dark blue line here, a level of social distancing of about 65%. If we see the level of social distancing in the state continue to drift down, that is where we could potentially enter back into this growth phase again. And it looks like we, maintain the ability to stay below our ICU bed capacity, which is this horizontal line drawn here at 1,800 ICU beds in the state. If we can keep our social distancing level, at 55% or better, we can probably, maintain disease transmission and not overwhelm our healthcare system. But if we drift back down to a level of social distancing of 50% or lower, that's where we potentially see once again this risk to overwhelming our healthcare system and exceeding the number of ICU beds we have available in the state. And so this is just some of the data that we're using over the next couple of weeks to really try and forecast where we might be headed and try and understand what disease transmission might look like in Colorado as we head into the fall. And with that, I will hand it over to Kirk.
Great, thanks so much, Dr. Herlihy. So thank you to both you and Dr. Armistead for the invitation to join the group today and present on just one aspect of the COVID-19 pandemic, and that's mortality due to COVID-19 as well as potential excess mortality during this period of time. So again, thanks for the opportunity. To Drs. Armistead and Herlihy, if you hear me cut out with my mic, just go ahead and ping me. It's been cutting out a little bit earlier today, so please let me know. But I'm happy to jump into some recent data regarding deaths due to COVID-19 during this period of pandemic. So most of the data I'm presenting are actually shared via public-facing websites, both from CDPHE as well as the CDC through the National Center for Health Statistics, and I invite you all to visit these sites through some of the references provided on these slides. But what we see in this first figure here is our deaths due to COVID-19 during this period of pandemic so far, up through data available as of last week. And this particular figure represents deaths occurring in Colorado, as well as those occurring in Colorado and registered via Colorado's vital record system through death certificates, representing deaths with either COVID-19 as an underlying cause of death or a significant contributing cause of death, as determined by our medical certifier community, that is the physicians, coroners, and medical examiners who certify Colorado's death certificates. And so what we see through this chart presented as weekly vertical bars is a series of weeks in April where we saw the initial spring peak of the COVID-19 epidemic in Colorado, with a high number of deaths during that week, mirroring the number of new cases then as well. And then certainly through the mid-summer period, we saw a slight uptick in deaths due to COVID-19 as well, again mirroring the increases in the numbers of cases during that period also. One thing I wanted to point out, since this is certainly a very hot topic during this time and up through now, is that for these deaths due to COVID-19, again, these are deaths occurring in Colorado, approximately 98% of these deaths in the state represent Colorado residents. And there's a small handful of cases of non-residents dying in Colorado or Colorado residents dying in other states. This is a very interesting aspect of mortality that is explored in great detail, particularly further east of Colorado, where there's a lot more interstate mobility of individuals with COVID-19 in terms of where they're diagnosed, where they die, and so forth. But this represents a very stable and solid number of deaths in Colorado and among Colorado residents during this period of pandemic. Of these deaths due to COVID-19 presented here, approximately 88% had COVID-19 as an underlying cause of death, as coded and determined by the National Center for Health Statistics, with approximately 12% as a significant contributing cause, again, as determined by our medical certifiers in the state. Next slide, please. So in addition to just that glimpse into deaths due to COVID-19 during this pandemic, we've begun exploring in greater detail this phenomena of excess mortality during this pandemic. So what does that mean? So during this period of pandemic, Colorado and the US have both experienced significant excess mortality, that is defined as the difference between the observed numbers of deaths in a specific time period, such as weeks in the year as presented on this figure, and the expected numbers of deaths based on the same time periods from previous years, accounting for some aspects of population growth and population change. And so in this particular figure, we see, as represented by the blue bars, the blue vertical bars, the observed numbers of deaths for each week. And the gold trend line through there represents the threshold representing excess deaths. So any bar exceeding that gold trend line indicates excess deaths during this particular period, where those red crosses then indicate, just as a flag, those weeks for which there were excess deaths observed. Again, these are numbers of deaths that exceed what we would typically expect to see given our mortality experience during similar weeks in previous years. Of note on this particular chart is that during a 4-week stretch starting in April, there were more than 1,000 deaths per week in Colorado for a series of that 4-week stretch, when we experienced just over 40,000 total occurrent deaths annually, or approximately 800 deaths per year or week. And so we have experienced significant periods of excess deaths all throughout this pandemic period. Next slide, please. And so we can see from this slide, just as quick orientation, the green bars represent mortality not due to COVID-19, whereas the blue vertical bars on top of those that are stacked represent deaths due to COVID-19. And again, the red crosses indicating a flag of excess mortality having been observed for that week. And so we can see from here that during this period, much of the excess mortality in Colorado has been attributable to deaths due to COVID-19, again, whether as an underlying or contributing cause, as seen through the blue bars. However, we also can see that deaths due to COVID-19 do not account for the entirety of the excess mortality in Colorado. And we will, as we'll just explore a little further, populations and communities in Colorado were affected slightly differently with regard to this excess mortality. Of note is that excess mortality is not just a COVID-19 phenomenon and is observed occasionally throughout the year, as represented by some exceedances in previous years, particularly during winter months, citing harsh flu seasons more often than not. And An unprecedented fact is that during the month of April, COVID-19 surpassed heart disease and cancer as the leading cause of death among Coloradans, with approximately 800 deaths due to COVID-19, compared to approximately 700 in the other categories. However, those other categories, we've seen some excess number of deaths as well. Next slide, please. So when we look at this phenomena of excess mortality in Colorado during this period of pandemic, we begin exploring it a few different ways. One is by age group. Most of the excess mortality occurred among older adults in Colorado, perhaps not surprising, as approximately 85% of deaths due to COVID-19 occurred among this population of those age 65 and over. But that is also where we see excess mortality across several other causes of death as well, as we'll see here in a little bit. However, we can also see through these slides wherein the red lines represent the mortality during the period of pandemic in 2020, and the gray lines represent similar weeks mortality in previous years, the previous 5 years, 2015 through 2019. Those red lines are quite high, particularly during the peak of the pandemic, but also in many instances the weeks since, for virtually all age groups, particularly those for adults in Colorado. Next slide, please. So looking at some general non-COVID-19 cause of death categories contributing to excess mortality, we observe the greatest excess mortality attributable to Alzheimer's disease and other dementias, which is the fourth category from the left, where we see the red lines exceed the gray lines in more weeks than across the other categories listed. However, we also do see excess mortality in these other categories, including circulatory diseases, cancer, and other select causes, and we'll dig into that. And those also include some of the injury-related mortality and other natural causes. And so when we see these deaths principally among the excess mortality, that is deaths due to causes other than COVID-19 being in excess, and also seeing them in diseases such as chronic diseases and Alzheimer's and dementia raises several questions, particularly for deaths due to Alzheimer's and dementia, which occur among our oldest populations. What is that interplay between COVID-19 diagnosis and certain chronic diseases, considering approximately 1/3 of deaths occur in nursing home, long-term care facilities, memory care facilities, and so forth? How does this play out in cause of death certification and the determination of cause of death between, say, Alzheimer's and dementia with an individual with COVID-19, and reflecting on the thresholds of, but for the presence of one condition or the other, is this person, does that person die within the time frame that they did? And so that represents certainly a challenge with our medical certifier community, and I would argue that they've done a tremendous job, both with regard to their medical opinions and death certification, as well as utilizing guidance from the CDC through the National Center for Health Statistics for classifying deaths due to COVID-19, while also capturing comorbid conditions and other conditions, including terminal conditions, that individuals may suffer from, so that we can paint as robust of a picture with regard to mortality as we can. But another aspect of excess mortality, as we see here, is whether among older or younger populations, how does the presence of COVID-19 affect things like care-seeking behavior? Considering the importance of chronic disease management and the potential need for immediate care in an acute complication event, such as a stroke, a heart attack, diabetic complication, and potentially individuals' reticence to seek care, particularly during this peak of the pandemic. What again raises a lot of questions about how did that care-seeking behavior change that is demonstrated by overall reduced hospitalizations and ED visits and EMS calls. How does that play into excess mortality and so forth? And so we, next slide please. So we can dig into some more localized data for leading causes of death here in Colorado. And so presented in this figure is a line graph of monthly deaths for 15 leading causes of death among Colorado residents from 2018 through 2020 year to date. So it's a bit of a busy chart in this way, but certainly standing out above all others is the dark blue line representing COVID-19 deaths, where we see, of course, 0 events up until March and peaking in April, and decreasing shortly after, but still persisting through this time in 2020. But among the busy lines in this figure, we can see other significant increases during pandemic in categories such as unintentional injury, which we'll dissect here a little bit shortly, and as well as COPD or chronic lower respiratory diseases, Alzheimer's disease, and some other natural causes and chronic disease causes. Interestingly, despite a small blip in April, we've not seen a significant overall increase in suicide deaths among Colorado residents. However, we would note that while suicide deaths may not have increased overall, we've seen some shifting of suicide deaths from firearm-related deaths to overdose-related suicides. Again, something that we will see in our next slide a little bit, where we look at some of the trends in violent deaths and overdoses in Colorado during this period of pandemic. And so we see in the blue line the overall numbers of suicide deaths by month in Colorado, which have remained relatively stable despite some increases actually in 2019. But the blue line, we end up ending about where we started a couple of years ago. Similarly with homicides in Colorado, as there's a significant interest in the potential for increase of homicides, particularly as it relates to intimate partner violence and so forth during the period of pandemic, we've not seen increases in our homicide numbers through Colorado thus far yet. However, we have seen significant increases in the unintentional and undetermined overdose deaths in the state. This is interesting in that it, particularly through April and May and June, we've seen some of the highest numbers of drug overdose deaths among Colorado residents that we've seen historically. That said, this phenomena of increased drug overdose deaths, again represented by the gray lines, isn't just a phenomena occurring during the COVID-19 pandemic, but has actually been a somewhat steadily increasing phenomena since mid and late 2019. As an aside, mirroring increases seen across the country and attributable in large part to overdoses involving illicit fentanyl being introduced in the system and warranting an entirely separate presentation and discussion there. One of the features of this figure you'll see is that in June and starting in the June and July period for the overdoses, a dramatic decrease in that or drop in that gray line. Please note that that's actually reflecting more of the incompleteness of the data and the lag in both registration of deaths due to overdoses as well as coding of those deaths. And we shouldn't make any inferences from those last couple of months of data, keeping in mind that the peak seen in May is the one that's presently most troublesome and garnering most of our attention. Next slide, please. And so now we've got another busy slide presenting some cause-specific mortality rates over time during this period of pandemic. These are actually figures produced by a research group based up of investigators from MIT, Harvard, and the Sergo Foundation that we've been partnering with and providing data to for some more detailed looks into excess mortality during the pandemic, including these detailed breakouts by other types of causes of death, whereas we see in the far upper left box that significant increase in all-cause mortality starting during this period of pandemic and through those earliest months. During that same period, we also saw dramatic declines in motor vehicle accidents, one of the injury causes that we have actually seen decreases in during this period. and that's in the upper left as well. So those most interesting findings that I thought were most interesting are all highlighted by orange or gold boxes around those trends during this period of pandemic. But moving across there, we've seen some decreases in work-related accidents during the period of pandemic. Again, those dramatic increases in drug overdose deaths, but which have been increasing since the beginning of the year as well. There were some early decreases in suicide this spring and into May as well. Of course, the box related to COVID-19 shows the most dramatic increase, as well as those death rates attributed to Alzheimer's disease and dementia. We see a fair bit of fluctuation around things like heart disease, cardiovascular disease, diabetes, and others. One thing to note in these particular figures is that the scale is actually quite small, and so some of these increases and decreases aren't as dramatic as they may appear, and so I welcome your eyes on the scales as well as you explore these further. Next slide, please. So looking at excess mortality across the state, the experience of excess mortality does vary from county to county. However, with the exception of some of Colorado's more rural and less populous counties, excess mortality is common and relatively uniform around the state. In this particular figure, we see in the kind of upper left triangle of this particular figure, those counties within Colorado that experienced more excess deaths than COVID deaths. And that is actually, I need to go back and review that piece a little bit further. I'm sorry, but what it represents is that those are counties that all experienced excess mortality in the state, and that COVID-19 is actually driving the majority of those excess deaths. Whereas in Morgan County, for instance, somewhat of an outlier there, we see a slightly different experience, but across the board, all counties have experienced some aspect of excess deaths, with a few exceptions of counties with small numbers, meaning single numbers of deaths in a given year, where statistically it's much more difficult to discern some of that excess mortality experience. Fortunately, through this group that we're working with out of MIT and Harvard, we're planning and conducting some additional analyses to explore mortality by race and ethnicity, as well as other community characteristics such as vulnerability indices, and trying to account for some of the mobility across the state of Colorado, distances to care, and so forth. So we're really looking forward to continuing to provide more data to these groups and work with them to process and publish more of this information for use as part of our response. Next slide, please. So also want to share some interesting data relating to morbidity during this period of pandemic, and grateful to our colleagues at Tri-County Health Department who administer Colorado's syndromic surveillance system, representing rapid ED reporting from Colorado's emergency departments to the system maintained by Tri-County Health Department to monitor rapidly changes during this period of pandemic. And so in this first glimpse looking at ED visits during the period of pandemic, particularly represented by the blue line, we see on the left side that total ED visits dropped or dipped dramatically during the peak of the pandemic, but have slowly returned to what we kind of consider some normal levels since then. But that plays into some of the concerns and potential hypotheses I raised earlier about changes in healthcare seeking behavior during the peak of the pandemic and since, and how does that potentially play into excess mortality, potentially related to complications of chronic disease and so forth. The orange line presented here represents ED visits associated with COVID-like illness. And so again, we see these most significant peaks during the early portion of the pandemic this spring, but tapering off pretty steadily in recent weeks, with slight increases in early and mid July as well, again mirroring some of the case experience in the state. And next slide, please, for the final glimpse into some of these data. We've also, through this syndromic surveillance system, our Tri-County colleagues have been able to monitor other aspects of ED visits during this period, including looking at ED visits related to, for instance, suicide ideation and attempt, alcohol overdose, opioid overdose, disaster-related mental health impacts, and so forth. And so they present a variety of these ED visit trends as well. Forgot to mention that the green vertical bars all represent different aspects of the public health response and specific public health orders enacted during this period. And so what we've seen here, kind of interestingly, is relatively stable numbers due to things like suicide, ideation, and attempt. And really, it's the ED visits for drug overdose deaths or drug overdose related events, not deaths, have not increased dramatically. We've seen some increases in alcohol related events, as well as for some of the other mental health related visits. But those represent fairly small increases during this period. And so we're not necessarily detecting a lot through ED visits, significant changes over time during this period of pandemic. And what's interesting in particular with regard to the overdose side of things, in spite of significant increases in overdose mortality during this period, we've not seen a commensurate increase in ED visits related to overdose. And part of this is, we suspect, is attributable to the nature of the drug overdoses and this introduction of fentanyl into the system last year, and some of the growing issues around that. And so certainly welcome additional eyes and insights into all of these findings, and look forward to being able to provide this and other groups additional updates over time. And so with that, I'll turn it over to our moderators for the conversation today.
Thank you very much, Rachel and Kirk. We appreciate the folks that have been putting questions in the chat. Please continue to do so. And I'm going to hand it over to Lisa Miller, who will pose some of the questions that have already been submitted.
Thank you. Thank you, Isaac. For those I don't know, I'm Lisa Miller. I'm the Program Director of the Preventive Medicine Residency and the Interim Associate Dean for Public Health Practice. And I just want to thank Kirk and Rachel for taking time out of their very busy days and weekends to share this information with us. So much information here. I think we could spend a whole hour with the information and then a whole hour discussing it and going through these questions. So I apologize, we just have a few minutes for a few questions, but we'll get to as many as we can. So let's go back and start with an issue from Rachel's presentation, and that's test positivity. So I think many of us as epidemiologists are a little bothered by test positivity because we don't really understand the numerator. So there's a couple questions that I think get at this. And one of them suggests that we look at test positivity among asymptomatic versus symptomatic folks, thinking that that would give us a little more information and standardize this measure a little more. And then there was another comment about how this measure might be influenced by people who are required to be tested and who don't really, aren't really at risk for disease, which gets at the whole notion of what things influence that rate. Things like access, things like publicity and encouragement to test. So I realize I wrapped up a whole lot of questions there, but can you talk about this sort of complicated measure that we use and we just present as one measure of test positivity?
Yes, and I mean, I wished we had all of those things, right? I wish we had more control over who was tested and why, and knew why they were being tested. In the case of positives, where we interview cases, we can collect some of that data. We can understand more about whether they had symptoms or not. We can understand more about their risk factors and what led to testing, including, you know, was someone tested because they were being admitted to a hospital for a procedure. And we've been trying to track some of that data for our positive cases. Unfortunately, for the denominator, we don't really get much information about negative test results, right? So all we really get is a name, date of birth, and the result of that test for those negatives. So we really don't have the ability to look specifically at symptomatic versus asymptomatic by positive versus negative test, or look at any other characteristics by positive versus negative test result. We are looking at ways that we might be able to enhance some of the data we're collecting. There are ways that we could potentially match our negative test data to existing data systems in the state. So data that we might have through COREO or QHN, where we could potentially match individuals, so we could get other baseline data on people like race and ethnicity and understand where we might be seeing gaps in testing in particular is one of the questions that we've wanted to answer. But right now it is limited data. It's yeah, we're not getting nearly as much information as we would love to get out of the data, and it is certainly biased by all of the things that were mentioned there, and that, you know, there are people who are being tested just because they're having a procedure done, or we know of individuals that get tested just because they're curious, right? So.
Right, yes. Like everything related to COVID, every one of these issues is so complex, and it's so hard to capture all this complexity. So we don't have a lot of time, so I'm gonna ask this question in a pointed way. There was a question about lessons learned, which is a really important question, but clearly we don't have time to go into all the lessons learned. So maybe, you know, what is the one thing that you would take forward as a lesson learned for the next event? And, you know, I'll give both of you an opportunity to address that.
Yeah, I think for me, the thing that stands out that we in the US didn't necessarily learn and adapt as quickly as Asian countries did was the important role of masks. It has taken us a really long time in this country to adopt this culture of mask wearing. And I think honestly, Colorado is doing a pretty good job compared to the rest of the country when we look at some of these national surveys around mask compliance. But I think it was a hugely missed opportunity with our spring wave of illness, where we potentially could have prevented many more cases and achieved suppression of the virus earlier than we did if we had, recognized the potential benefit of mask wearing.
Yeah, and with regard to the mortality piece, I think one of the major lessons we learned with that, irrespective of excess deaths and how we treat those, just in that broader picture of mortality, I think the biggest lessons we learned were more around communication and working with a population that is really uniformly affected by COVID. Dr. Herlihy referenced early in her presentation, and as a rationale for why this talk focuses so much on COVID-19, which is that it is a topic that's affecting all of public health, and in fact, all of our population. It's not a niche public health problem like many of them might be, but rather everybody's affected in one way or another. And so with regard to nuances in presenting data and trying to share detailed interpretations and definitions and working with our media partners and other outward facing groups, one of the biggest lessons I know I've learned and our team has learned was with regard to the communication side and working with an increasingly data savvy and in many instances, increasingly scientifically literate population who wants to ingest so much information and is able to work with it. And so our goal is moving forward certainly to make information available and to help support good interpretation, good application of this information, and requiring us to be more mindful, I think, moving forward too, about just getting ahead of some of this information and making sure details are available to folks up front, trying to minimize concerns around hiding information or anything like that. So So that's a big piece from the data and kind of data literacy and communication side that we learned.
Right. Let me get in one more question about the mortality. So from Dr. Janich, could it be that Alzheimer's deaths have COVID as a contributing factor as these people live in assisted living facilities where they may have difficulties social distancing? So are those Alzheimer's excess deaths, those were deaths where COVID was not noted to be a factor, correct?
Not exactly. So that these were deaths. When looking at deaths by specific causes, we generally look at the underlying cause of death, and so that final cause of death determined both based on the death certificate and through coding of that information to be kind of that most upstream cause resulting in death. However, it is true that the many of the deaths attributed to Alzheimer's as an underlying cause of death also had COVID-19 mentioned as a contributing cause. And so those overall death numbers of deaths due to COVID-19 that we present that include both underlying and contributing causes would include those with Alzheimer's who died for which COVID-19 was listed as a contributing cause there. And so it is our, absolutely, I think that insight is spot on in as much as within our long-term care facilities, nursing homes, and so forth, many of those deaths due to Alzheimer's involved COVID-19 and were likely subject to some of the challenges with regard to distancing and so forth in those facilities, particularly early on. It is our goal with these data to parse this out into more detail and be able to share more information on the frequency of deaths where COVID-19 was listed as a sole cause versus associated with other associated causes, and when it might have been secondary to something like Alzheimer's as an underlying cause. So these are some of the details we hope to continue to spell out and share with folks moving forward.
Got it. Thanks, Kirk. I want to thank Emily Wu, who responded to a couple of the modeling questions in the chat. So if you hadn't seen those answers, please look at the chat there for the answers to some of those modeling questions. And then maybe for the final question, it's a little after 1, but I'll ask Rachel to finish up with an appropriate question, which is, when should people get their flu shots?
Yeah, so I would say now. I mean, I think we in general worry about missed opportunities much more than we worry about individuals getting their influenza vaccine too early. You know, I think at this point it's mid-September, getting into October. I think the time is now for people to start getting their flu shots.
Okay, so we'll leave it on that excellent public health message. And again, thank you both for taking this time, and thank you for all the work that you do with the School of Public Health. We really appreciate it. Also thank you to everyone for joining us, for putting some great questions in the chat. Sorry we didn't get to all of them, but we appreciate your interest and your involvement. So with that, we'll wrap it up and wish everyone a good week. Thanks.